Good morning, everybody. Welcome to MGFA's Wellness Series webinar, Women's Health and MG. I'm Jenna Umbalo, and I will be moderating today's session. Before we get started, I'd like to go over a few housekeeping items. If you have questions or comments, please submit them in the Zoom Q&A box located at the bottom of the screen, and we'll answer them during the Q&A segment. I'd like to give special thanks to our sponsors for the Wellness Series, Alexion, Argenx, UCB, Janssen, Cabaletta Bio, and Horizon. And we've got a great presentation ahead. And now it's my pleasure to introduce today's speaker, Dr. Afra Janarias at the University of Central Florida. I'll hand it over to you.
Thank you, Jenna. My slides are up, I hope. Thank you for the invitation. I'm really excited to be speaking to you today about this topic. We'll be discussing the impact of myasthenia on women's health. Today's talk will start with why the topic of women's health is of particular importance in the management of myasthenia. Then we will specifically discuss concerns including family planning and management of myasthenia during and around pregnancy. We know that myasthenia is not a homogeneous disease, but rather composed of various subtypes. We use classifications including antibody status, association with thymoma, age of onset to subcategorize myasthenia. In early adulthood, women are more than twice as likely as men to be affected with generalized myasthenia gravis. And then after age 50, generalized myasthenia incidence is higher in men. What this amounts to is that women experience myasthenia.
So sorry. Can you share your screen because we're not seeing the slides from our end?
My apologies.
No worries.
I'm just going to rewind. Are you seeing my screen now?
Yep, that's perfect. Thank you.
So this was our agenda, and I'm just showing you the subtypes of myasthenia, including age, thymoma status, antibody status, and then the likelihood of having myasthenia is much higher for women when they're young than for men. And so what this amounts to is that women experience myasthenia earlier in their lives than men. The mean age of onset for women is 35 years old compared to 46 years old in men. And that's not to say that myasthenia does not affect younger women. Many women are affected since their early 20s, and then men are often older when they first present with weakness. I'm repeatedly emphasizing the age of onset of myasthenia because regardless of whether myasthenia starts at age 25 or 35, these years are prime years of health, productivity, and childbearing. The mean age of first birth in the United States has been rising in the last generation and is now 26 years old. And as physicians who take care of people with myasthenia, it's extremely important to understand the nature of myasthenia as it affects young women. To start, I want to discuss the impact of menstruation on weakness related to myasthenia. In the late 1990s, Israeli researchers sent a questionnaire to a group of 120 myasthenic women, asking them about their myasthenia symptoms. Of the patients who responded, 42 women were premenopausal, and those are the women whose results were included in this study. The mean age of the responders was 35 years old. Of these women, 2/3 noted a worsening in myasthenia symptoms before and during their period. Worsening of their symptoms was defined as double vision, difficulty speaking, chewing or swallowing, or limb weakness. Researchers were careful to tease out whether abdominal pain or cramping was correlated with worsening symptoms, and they found that wasn't the case. They also looked at whether women taking particular immunotherapies had more frequent exacerbations during their menstrual periods, and they found that no specific therapy was associated with a higher likelihood of exacerbation. They also noted that oral contraceptive use did not affect the frequency of perimenstrual exacerbations. To add further support for the hypothesis of perimenstrual worsening of myasthenia, there's a widely cited case report published in 2007 by researchers in South Carolina. A young woman who had very symptomatic myasthenia with antibodies to musk had always noted that her symptoms were worse during her menstrual period, particularly when she started the placebo pills in her oral contraceptive pack. Researchers collected data on the activity of her myasthenia by performing single fiber EMG on her frontalis, which is a facial muscle. They found that when she was on her period, she had active myasthenia electrically, as demonstrated by her single fiber EMG. And on exam in person, she had facial and limb weakness too. In this young woman's case, researchers performed an intervention to try to help her, in which they placed the patient on continuous oral contraceptive therapy without the placebo week. This is intended to stop her menstruation altogether. At 1 month following the intervention, they re-examined her and found that her limb strength was improved, but her facial weakness was still prominent. They did the EMG again, and they saw that her electrical testing was still abnormal. And it was better than previously, so they continued the oral contraceptive therapy. And then at 6 months, they saw that the patient had markedly improved electrical parameters or reduced mean jitter values compared to initially. Her findings on single fiber EMG were still consistent with myasthenia. And on exam, she still had some facial weakness, but her overall limb strength and her overall electrical parameters were much better. It's a single study, so the power of this evidence is considered really limited, but it is highly supportive of the data that myasthenia is often active during menstruation and less active in times without menstruation. And this study was actually cited by almost all of the experts in the literature regarding women and menstruation. My final takeaway on this issue about menstruation is that it might be worthwhile as women to keep a log of symptoms during the menstrual cycle and see if there's any correlation with myasthenia symptoms. And then if you do find that's the case, talk to your doctor about it. I will say that the data on this is really not very strong because the previous study was 42 women, there's a single case report. So it would be great if more research in this area were conducted at large centers with lots of myasthenic patients to more conclusively answer that question. Let's move on to talking about family planning and pregnancy in myasthenia. As we have already discussed, myasthenia gravis affects young women in their prime childbearing years. When I was a fellow a couple of years ago, I remember taking care of a young woman who really wanted to get pregnant, but had recently found out she had myasthenia. She was concerned about family planning, and she came to my mentor, Dr. Namita Goyal at UC Irvine. And Dr. Goyal came up with a plan, and she managed to control the patient's myasthenia very well during her pregnancy, but there was a lot of angst, there was a lot of worry on the patient's part before she came to us for help. It turns out that women with myasthenia sometimes plan their families around myasthenia. In a 2015 German study, including over 600 women aged 14 to 92 with myasthenia, only half of women reported that myasthenia did not affect their family planning. But these are actually the women who had completed their families before their myasthenia started. When researchers narrowed the data further, for the 46% of women whose myasthenia onset occurred before they completed the families, 80% of these women said that myasthenia influenced their decision to have children. They're concerned mostly about the effect of myasthenia medications on their unborn child and myasthenia worsening during their pregnancies. And among these women, fully half of them reported abstaining from having further children because of their myasthenia. These women were not wrong to be concerned. Myasthenia can worsen during pregnancy, and there are risks of birth defects in some medications used routinely to treat myasthenia. However, with a proactive approach to medication use prior to pregnancy and during pregnancy, these risks can be mitigated. Women should plan to work with a team of neurologists, obstetricians, and anesthetists during pregnancy and plan to deliver at a facility with access to these specialists. It's important to recognize that planning and having a family can span years and can include a long pre-pregnancy period, a long period of trying to conceive or short, and then pregnancy or pregnancies, and postpartum concerns as well, including lactation. Therefore, as physicians who care for women with myasthenia, it's important for us to be having frank discussions about family planning, even if the patients never raise the question. And then as patients with myasthenia, it's important to raise the question early. And this allows optimization of medications to suit the goals of women with regard to family planning. Early after the onset of myasthenia, physicians who care for women with myasthenia should clarify the goals of these women with regards to pregnancy. So we should ask, have you guys already completed your family? Do you hope to become pregnant in the future? What will the timing look like? And in patients with seropositive generalized myasthenia, there should be a discussion about thymectomy. The thymus is a lymphoid organ in the upper chest, right behind the sternum and above the heart. Its primary purpose is the so-called education of stem cells into functional T lymphocytes. These mature T cells then migrate to other lymph organs like lymph nodes and the spleen and circulate through the body as part of the immune system. The thymus is fully developed at birth and in early childhood produces mature T cells, shown here, which are long-lived and self-renewing. But over time, the thymic tissue is gradually replaced by fat, which is called thymic involution, and it's a normal process. The body's T cell repertoire and immune function remains unaffected by this process of involution. And here they've shown a sample of a thymus from a 3-day-old infant and another sample from a 70-year-old person, and they're both normal. In myasthenia, 15% of patients have a thymoma, which is a tumor arising from thymic tissue. And then another 65% of myasthenia patients have thymic lymphoid hyperplasia or thymic hyperplasia. When imaged by CAT scan, thymic hyperplasia can look like a normal thymus, or it can even look like an enlarged focal thymic mass. Thymic hyperplasia is believed to play an important role in the pathophysiology of early onset myasthenia, which, as we discussed, is a disease onset before age 50 and the kind that more often affects women. That's all to say that the thymus, thymic tissue, is a very important part of the disease-causing problem in myasthenia, and removal of the thymus or thymectomy is standard of care in generalized myasthenia. We know that from robust studies, it's helpful to have a thymectomy in the management of myasthenia. This is data taken from an international randomized controlled trial, the MGTX trial. What they did was they looked at men and women with generalized myasthenia, aged between 18 and 65, and they had two groups. They had a group who had thymectomy and used prednisone for treatment versus a group that just used prednisone alone. And they looked longitudinally over their outcomes, including their use of prednisone over time and their outcome scores in terms of their strength. And they found that in patients with thymectomy versus patients without thymectomy, they had improved symptoms of myasthenia in a sustained response over years, and reduced the required dose of prednisone for these patients as well. Specifically for women who want to become pregnant, the role of prior thymectomy has been examined in pregnancy in much smaller, they're not thousands anymore, less robust studies. And from the retrospective reviews we have available, we see that thymectomy before pregnancy reduces the risk of neonatal myasthenia by about 50%. And we'll talk more about neonatal myasthenia in the subsequent slides. So this data was taken from a retrospective review of the Norwegian population. They also found that previous thymectomy did not have statistically significant effect on complications during pregnancy or delivery interventions or C-sections or myasthenia exacerbations. Okay. So when I say thymectomy reduces the risk of neonatal myasthenia, what do I mean? So there's an entity called transient neonatal myasthenia, which occurs in the range is big, between 6 and 20% of infants born to mothers with generalized myasthenia. It can occur in women who are acetylcholine positive or MuSK positive. What happens is the maternal antibodies migrate across the placenta and cause a transient period of weakness in the baby that shows up in the first few days of life. It can even be suspected prior to birth. Signs prior to birth include polyhydramnios, which means too much amniotic fluid, and it's due to the poor swallowing of the amniotic fluid that the fetus normally does. And the signs after birth in the infant include low muscle tone, so the baby may be very floppy, poor, stuck, and weak cry, and breathing difficulties, which can be severe and life-threatening. Luckily, this weakness is usually very transient and improves within a few weeks to months of life. Like I said before, from the evidence we have already, the risk of neonatal myasthenia is markedly reduced if the mother had previously undergone thymectomy. But as I showed you before, the study was quite small, and I think more work in this area should be done because there aren't that many robust studies to answer this question. Much more rarely than that, and I don't have a specific number on this, I couldn't find one, but everybody says it's just rare. Infants born to mothers with myasthenia can have more lasting weakness in the face and body, and that's called persistent myopathy. They could also have had weakness in the womb so that their joints come bent and contracted in a few different places, and that's called congenital arthrogryposis. Unfortunately, the likelihood of these complications is really hard to predict. It's not correlated with disease severity in the mother. But if a woman has had an infant who had these issues in previous pregnancies, then plasma exchange or IVIG should be offered in the subsequent pregnancies to reduce the risk of these complications. Further, thymectomy is not an experimental therapy. The 2020 International Consensus Guidance for Management of Myasthenia Gravis recommends thymectomy should be considered for generalized myasthenia patients age 18 to 50 early in their disease course, which is about 5 years. Change gears and talk about fertility. So in a lot of the reviews published by very famous experts, they write that fertility is not affected by myasthenia gravis. But what I did was I reviewed the literature widely regarding immunosuppression, and I found that there is some effect on fertility for men. So fertility for men is affected by methotrexate and by steroids. And then rituximab is discouraged in both men and women who are trying to conceive. And then I looked for this question of assisted reproductive therapy for patients who've had difficulty conceiving. And it has really not been well studied or studied at all in myasthenia. There was a single case report. So an Italian infertility center reported their experience in doing a specialized kind of therapy called ICSI, or intracytoplasmic sperm injection, in a woman who had generalized myasthenia gravis. So what ICSI is a therapy used for male factor infertility or people who have previously failed IVF. And what happens is a specialist will inject a spermatocyte into an oocyte, which was harvested before from the mother. And then it allows the embryos to grow in culture. And then these embryos, when they're ready, are transplanted into the uterus. But in order to prepare for harvesting those eggs, the woman has to take numerous hormones. As we discussed before, there's some concern that myasthenia can change with hormonal fluctuations. So in this single case, the woman underwent 4 different cycles of egg maturation with hormones, retrieval, and then implantation. And all through these 4 cycles, her myasthenia was stable. She was on IVIG and prednisone. And the couple, unfortunately, they were not successful in achieving a pregnancy. This is a single case at a single center, but is another area where more data is needed, more work is needed to understand how myasthenia may impact assisted reproductive therapy. When women are not planning to conceive in the near future, effective contraception should be used, especially when taking medications like methotrexate, mycophenolate, and biologic agents like rituximab, eculizumab, efgartigimod. There's no known effects of contraceptive use on myasthenia activity. And then when women are trying to conceive or planning to conceive in the near future, myasthenia should be optimized and medication choice should be evaluated. There are certain medications that should be stopped before contraception is stopped. These include methotrexate, which should be stopped 3 months before trying to conceive, and mycophenolate, which should be stopped at least 6 weeks before trying to conceive. And then rituximab should actually be stopped 12 months prior to trying to conceive. Steroids and pyridostigmine, which is mestinon, can be used through pregnancy. And then IVIG and plasma exchange can be used during pregnancy, either for maintenance or for exacerbation. And then looking deeper regarding the medications that we are talking about as safe during pregnancy, there are still risks associated with them. For example, corticosteroids can increase the risk of gestational diabetes, of intrauterine growth restriction, preterm delivery, and infection. So to take steroids, we recommend using the lowest effective dose. And if it's needed, it's needed in pregnancy to control the myasthenia. Pyridostigmine is considered safe in pregnancy and lactation. And then azathioprine, for the most part, is considered safe. Some experts have mixed opinions, but the general consensus is that it can be used during pregnancy and lactation if it's needed. But in men who are trying to conceive, there is a risk actually of causing mutations in the sperm. Two medications that cannot be used and must be discontinued prior to pregnancy are methotrexate and mycophenolate. Both of them are associated with birth defects and miscarriage. Neither methotrexate nor mycophenolate can be used when breastfeeding. For those women who may have transitioned off medications like mycophenolate prior to pregnancy and require additional immunotherapy beyond corticosteroids, regular IVIG or plasma exchange can be used in pregnancy. And that's what we did when I was a fellow. That's what Dr. Goyle did for our patient. And then for myasthenia exacerbations during pregnancy, either of these therapies can be used. Tacrolimus can be used with caution during pregnancy, but there may be some risk to the fetus. And as we discussed before, rituximab should really be discontinued many months prior to conception. It really hasn't been studied well enough to know the risk during pregnancy. And then newer medications like Soliris, Vyvgart are not recommended during pregnancy and lactation due to lack of evidence. For Soliris, also called eculizumab, there is some data for use in pregnancy for women with hemolytic uremic syndrome, not myasthenia, because it's also indicated for that. And we know that for those women, they can have immunosuppression in the baby. But to my knowledge, there's no studies regarding the use of eculizumab in women with myasthenia with pregnancy. And then what happens in the overall course of the pregnancy is a matter of curiosity. So as we discussed before, women with myasthenia who are pregnant should be managed with a team. So that includes a neurologist, an obstetrician, and an anesthetist. And a meeting well before labor should happen with the anesthesia team to talk about what agents are safe in myasthenia. And then women, these are not the women who should have home births. Women should give birth at a center with a neonatal intensive care unit and with access to specialists. It should be mentioned that during the course of pregnancy, some women actually experience improvement in their myasthenia symptoms. Something like 20 to 30% of women feel their myasthenia is improved clinically. But then for others, there is a risk of myasthenia crisis during pregnancy. And the range of how frequently that happens is 20% to 50% in various articles about myasthenia in pregnancy. The treatment, if myasthenia crisis does happen, is the same for a pregnant woman and a non-pregnant woman. So we treat with IVIG and plasma exchange after making sure the patient is breathing. It might require intubation. So stabilize the airway, treat with IVIG and plasma exchange. And if it happens in one pregnancy, it doesn't mean that it's going to happen next time. So it's not predictive of myasthenia crisis in a subsequent pregnancy. And then there are other pregnancy complications unrelated to myasthenia, such as preeclampsia and eclampsia that occur in a minority of pregnant women in the United States. These are life-threatening blood pressure disorders that can cause seizures, and so aggressive management is mandatory. But the first-line treatment that's often used, magnesium sulfate, can cause a myasthenia exacerbation. So what experts are writing is, if you can avoid it, try to avoid it, or if you cannot avoid it and must use it, it should be with the understanding that myasthenia crisis can happen as a result, and appropriate management of the pregnant patient should be made to handle a potential myasthenia crisis. And then because these are also problems with blood pressure, the specific blood pressure medications that we use are not recommended in myasthenics either. So beta blockers, calcium channel blockers should be avoided, and instead other blood pressure meds like methyl-dopa and hydralazine should be used. And that's why a discussion well before labor or delivery, early in the pregnancy is very important. And then regarding how to deliver, what is the labor like? So there's no reason that a myasthenic woman should not have a vaginal delivery if she's doing well. So C-section is not mandatory in all myasthenic women. Epidural is recommended at the time of labor because it's been shown to reduce C-section rate in myasthenic women. In some women who, by the time they get to labor and delivery, are quite weak, so they have slurred speech or difficulty swallowing or clear difficulty breathing, those women should go directly to C-section, even if the baby is fine and there's not an obstetric indication to have a C-section. And then during labor, the first stage of labor, the uterus does the work, and the uterus is smooth muscle, which is unaffected by myasthenia. The second stage of labor is where myasthenia can affect the delivery. And in these cases, if women need help, for example, they can get menstruation to reduce their fatigue, or in these cases too, sometimes assistive devices can be used for delivery. And then postpartum, once the mom and baby are sort of done with that work, surveillance is very important. So they should stay for at least one night to monitor for worsening of the myasthenia or for infection. And those should be aggressively treated. Pardon. So for many women, breastfeeding is an experience they do not want to miss with their infant. There's so many benefits for mother and baby from breastfeeding. And so myasthenia, you should know, is not a contraindication to breastfeeding. The infant is not going to get the antibodies for myasthenia from breastfeeding. They're not going to get myasthenia symptoms from breastfeeding. However, based on the meds the mother is taking, the risk and benefit of lactation should be evaluated carefully. So for low-dose steroids and menstruation, with the addition of azathioprine, lactation can commence. That's fine. All of that is acceptable. But mycophenolate and methotrexate should not be used in breastfeeding mothers. And then I want to add this. It should be noted that in the US, we have a very, very strong pro-breastfeeding culture in the US, which is wonderful. It's good for mom. It's good for baby. But there sometimes is a discouragement from supplementation with formula. And that's something to consider carefully in myasthenic mothers, because breastfeeding can be very challenging. It can cause significant sleep deprivation. It can make it more challenging for other caregivers to help mom with the baby. And so considering supplementing and not being a hardline breastfeeder is something to strongly consider for myasthenic mothers, because it's important for them to get rest so that they don't have an exacerbation just as they've gotten their baby. So before I close, I want to walk through the pregnancy stories of two real women with myasthenia. I never met these women. These are actually described in a paper written by a couple of German neurologists, and I think they're very illustrative. So the first is a young lady. She was diagnosed at age 19 with mild generalized myasthenia with positive antibodies. Unfortunately, she had a crisis 3 years after her diagnosis, and in that same year had thymectomy. Luckily, she was able to achieve remission with azathioprine and pyridostigmine, but after a time, she actually developed an infection of her heart, and she had to stop the azathioprine. She continued to do well on pyridostigmine alone until she became pregnant at age 26. Her pregnancy was very smooth. She didn't have any exacerbations, and she went into spontaneous labor at 37 weeks. But she delivered a low birth weight baby who had no spontaneous breathing, was floppy, had low muscle tone, and was unable to suck or swallow at all. So the baby was kept in the neonatal intensive care unit and was treated with IV pyridostigmine until he was 19 days old. And then he was discharged home. And then at 30 days of life for the baby, he was doing very well. He was moving around on his own. He had gained a lot of weight. He was crying aggressively, he was drinking, he was swallowing without difficulty. And so then after that period of time, pyridostigmine was taken off. Mother did very well postpartum. She didn't have complications or a crisis. So that's case one. And I highlighted that because the patient was doing well prior to pregnancy, did well during her pregnancy, and yet had a patient with a baby with transient neonatal myasthenia. In the second case, there's a woman who was diagnosed with myasthenia at age 35. And she had a moderate severity generalized myasthenia and had a myasthenia crisis early in her disease course. She had thymectomy the same year. She actually had a thymoma, which might explain why she was a little bit more challenging to control. She had another myasthenia exacerbation right before pregnancy. She stayed on azathioprine during her pregnancy, which she conceived at age 37. And then at term, she had the C-section delivery. And from the article, I'm not sure if she had C-section electively or if there was a clear indication because she had weakness, but she had a C-section and delivered a very healthy baby with only very mild respiratory weakness. He stayed in the neonatal care unit for just a day, and he was doing quite well, so was discharged home. And then mom didn't have any exacerbations during her pregnancy or after her pregnancy. She didn't choose to breastfeed, to continue to take azathioprine postpartum. And I wanted to highlight these two cases because it kind of shows that myasthenia gravis certainly does affect pregnancy and pregnancy outcomes. And second, that pregnancy and delivery of healthy children can be managed in the right hands at a good center. So it's very important for women with myasthenia to have a health team that is knowledgeable about myasthenia and to plan to deliver the baby at an institution that can handle both maternal myasthenia and transient neonatal myasthenia. To close, I want to emphasize that myasthenia affects women in their prime childbearing years. And so because of that, when women are talking to their doctors about myasthenia, they should talk to their doctors about family planning, even if the doctors don't bring it up first. They should talk to their doctors if they have generalized myasthenia about thymectomy earlier in their disease course, because it can improve their outcomes from the medications they use to their strength to their pregnancy outcomes. And then planning even months and years ahead is important in myasthenia medication management for women who may want to conceive or have another pregnancy in the future. And then finally, I want to emphasize that with good care, women with myasthenia can have safe pregnancies and healthy babies. That's what I have today. Thank you for your attention. I'll take questions if there are any.
Thank you so much. We do have some questions. So the first one is, I am premenopausal and in the middle of the worst flare-up I've experienced since being diagnosed in 2018. I am 50 years old. Can MG worsen around the time of menopause? And how can I better manage it during this time?
That's a really good question, and I don't have the answer off the top of my head. From the studies that I've highlighted, we do know that MG can worsen with hormonal fluctuations, but there's really not strong data. Those studies are very, very small. I would talk to your neurologist and see if there's anything medically from the neurologist toolkit that they can do to optimize the myasthenia. And then if they're happy with your control, if they're comfortable with where you are, then the next step is to talk to your OB and see if they can help you maybe stabilize your menopause in another way. But unfortunately, we just don't have great data for me to tell you specifically.
Thank you. This next question is, will my baby be born with MG if I have MG?
No, not necessarily. So the majority of myasthenia gravis, and I spoke only about autoimmune myasthenia gravis, the majority of myasthenia gravis is autoimmune. So women with autoimmune myasthenia gravis have a small chance, they have a minority chance of having a baby who for a short period of time may have symptoms of myasthenia, but that's usually quite transient and goes away with appropriate care. So the short answer is no. There's a very rare population of people who have congenital myasthenia, so they actually have genetic cause of myasthenia. And in those people, sometimes, yes, their baby is born with myasthenia. But for the grand majority of people listening to this, the answer is no.
Okay. This next question is, how can I participate in a study to help other premenopausal women with MG?
Good question. I'm not aware of any ongoing studies, but you can always find studies on clinicaltrials.gov. And if you live close to an MG partner or a large center for myasthenics, you can specifically ask your physician there and they should be able to tell you.
Okay, thank you. Can you please repeat the list of the 3 specialists that you said to have on your team?
A good neurologist who understands myasthenia care, obstetrician, and anesthetist or anesthesiologist before delivery, well before delivery.
Great, thank you. Is it true that autoimmunity in general is hereditary?
There's different patterns. So yes is the short answer. There are different HLA patterns that predispose to autoimmunity. And we do see that, that women with relatives who have autoimmune illnesses may be more prone than others.
Okay, thank you. This next one is, I had a thymic tumor before I was diagnosed with MG. The thymus was removed by thymectomy in 2012, but I showed no symptoms of MG until 2018 when I was officially diagnosed. Is this unusual?
So it is an interesting question. Some experts call myasthenia gravis a paraneoplastic disease in the sense that sometimes there's a tumor, a thymoma, and then there's antibodies to the tumor that cause an illness. I don't think I've ever seen a case where the thymoma was discovered years before symptoms, but I have taken care of many patients with paraneoplastic diseases in which the illness was far removed from the time that the tumor was discovered. Either it preceded it or it was well after it. So I think, another thing to consider is making sure that there's no residual thymic tissue left over. If you had your resection many years ago, just make sure that, someone's taking a good look to make sure that nothing's grown back.
Thank you. And then you covered a lot about medication considerations throughout pregnancy and before pregnancy. Are there any other overall health and well-being considerations that an MG person should consider in either preparing for pregnancy or during pregnancy?
Yes. So unfortunately, women with myasthenia are put in this terrible place where many of them have to take steroids and are also told to be as healthy as a horse before pregnancy, even though they may be gaining weight no matter what they eat, and their blood pressure may be high, and they may be more tired than usual because they don't have as much energy as someone whose muscles work perfectly. It's challenging, but the same American Heart Association recommendations are 30 minutes of moderate activity a day, and moderate activity is gardening, vacuuming your house, taking a sort of brisk walk around your neighborhood, walking your dog. It doesn't have to be jogging or playing tennis, but doing 30 minutes of that a day, 5 days a week is recommended. Doing your utmost to keep your weight in the normal range is very important because you are at a higher risk of gestational diabetes if you're obliged to take prednisone during your pregnancy. And then there's some studies about vitamin D reducing fatigue. So it's something to talk to your doctor about if you have vitamin D deficiency, should you take vitamin D ahead of time. But The same general recommendations we give to women who are not myasthenic also apply to myasthenic women. It's just y'all have it a little harder.
Great, thank you. And then one last question is, you said that most MG is autoimmune. Please speak of the other types of MG.
So like I said, most myasthenia gravis is autoimmune, and the most common antibody is the acetylcholine antibody. There are some less common antibodies like MuSK, LRP, and then there's a few more. But they're antibodies to certain proteins in the neuromuscular junction. And the neuromuscular junction is composed of other small proteins. And proteins in the human body are encoded by DNA. And so every once in a while, some of that DNA has a mutation that might be for one of those neuromuscular junction proteins. So there are maybe a dozen genetic forms of congenital myasthenia. And if it happens that a baby is born floppy at a large center, there's almost always a geneticist on hand who can start the process of searching for a cause. There's some really big panels that can be sent for completely free that include the genes responsible for congenital myasthenia, and that's what it's called when babies are born with myasthenia. And some women who had such mild symptoms their whole life are first diagnosed with congenital myasthenia when their baby is born with congenital myasthenia. And I remember seeing that when I was a fellow, that mom didn't know she was just a little bad at PE. Mom didn't know she actually had myasthenia. It was when her twins were born floppy that they were diagnosed genetically, and then going back in time, mom was diagnosed. And then everything starts to fit into place. But this is quite rare. I think I've only seen one case so far in my career of congenital myasthenia. So the grand majority of women have autoimmune myasthenia.
Thank you. And we did get one other question, that is, what are the main causes of MG flare-ups?
So we always look for infection. That's one problem that can cause an MG flare-up. Medication non-adherence, maybe you missed a couple doses, or the medication was adjusted too fast. I remember Dr. Goyle, who's my mentor, who is such a good doctor for myasthenia gravis, very slowly would take the prednisone down. But for some doctors who are not as cautious, maybe as she was, who go down a little bit faster on the medication, sometimes the myasthenia flares back up. So medication changes, whether that's from non-adherence or from us going too fast with the medication reduction, and infection are the biggest, and stress is another one, which is why I wanted to emphasize that in the lactation portion of this talk, because I do think that, you know, women want to be perfect. There's a lot of info about being a perfect mom, feed your baby organic, breastfeed, only wooden toys. You don't have to be perfect to be a good mother. You should be healthy to be a good mother. So I think reducing stress and being organized as a new mother with myasthenia is very important to reduce the risk of exacerbation.
Thank you. That concludes our talk today. Thank you so much, Dr. Janarius, for the wonderful presentation and the wealth of information. This recording will be available online later in the week. We thank you all for joining and look forward to seeing you on future webinars.
Thank you.